Thank you for joining us on our OTT discussion about the vaccine rollout. And for this conversation, I'm joined by WCPO's Larry Seward, the Health Gap's Renee Mahaffie Harris, and UC Health's Dr. Carl Fichtenbaum, who is an infectious diseases expert. So thank you all for being here. What I'd like to do first is start with a very general question, that being, since the December vaccine rollout, what have you all learned? And Larry, let's start with you.
We don't have enough vaccine. That's what we've learned. I mean, every week, every day, we're hearing phone calls, emails from viewers, people that are concerned about, hey, I'm eligible. I want to get the vaccine. I can't get an appointment. I can't get a dose. I mean, all of those are problems. And I don't know when the end of this problem will be coming, but that's the biggest thing that I've seen so far.
Okay, Renee, what about you?
I would agree with Larry that the access to the vaccine, while people who are 80 and up and now 75 and up and now I think soon to be 70 and up are eligible, there is not enough vaccine. And so when health systems and our health departments get the vaccine, it goes fast. And so keeping people being patient, and we already have the issue of mistrust. And so when a system then can't respond to the vaccine when someone said, okay, I'm ready to take the vaccine, I'm concerned that that impacts the mistrust.
Okay, Dr. Fichtenbaum.
Yeah, I think we learned that planning matters. It matters when you plan or when you don't plan. And so what we have experienced since February, when we began almost a year ago attacking these issues, that when we don't have a clear plan and we have all of the resources needed to execute that plan, we have problems. And so we have seen our supply chain cause many problems, first with testing and our ability to test people. And now we're seeing it with our ability to supply vaccine in a rapid manner to a population that is literally wanting it, as soon as they can get it. And I think this shows some of the weakness of our entire national strategy before, and also some of the weaknesses of our public health system, which is not really geared toward taking an incredibly large, complex country like ours and really making something happen on a dime.
Okay, so on that note, should there have been a federal plan that would have guided all of the states? That's question number one. And question number two is, can you really adequately roll up production of something that is tough to produce, such as a vaccine?
Well, I think absolutely there has to be a federal plan. It is really hard for 50 states to create 50 different plans and then all the municipalities within. And we have also learned that when one state tries to procure something, another state is trying to procure it. And how do we decide who gets it first? So we really need a federal plan, and we need a federal plan now. We needed one before, but we need one now. So I think that's probably the most important thing that we really needed then, and we still need it now.
Okay, vaccine production, how difficult is that? I can't imagine that's an easy endeavor to ramp up from nothing to a global supply.
Yeah, so we have two vaccines that have been approved by the FDA, one by a company that has global reach with a lot of manufacturing capability, Pfizer, and another one that is a very brand new company that never brought a product to market. Now, we have already known for many months that these vaccines were likely to be successful, and there should have been a plan to say, when it is successful, how are we going to manufacture it? What supplies will you need? Do we need to have factories ready to build or repurpose? It turns out the mRNA vaccines are actually the easiest vaccines to produce. And that if we have the right setting for them and the sterile conditions needed and the appropriate, what we call GCP or good clinical practices and FDA seal of approval, we could put into place a lot of manufacturing in not such a slow pace of time. I think right now, without a clear mandate and help and support, the companies themselves are looking to say, well, how do we get the supplies we need? How do we get the space we need to build a new factory? How do we get what we need? And Pfizer, of course, has a worldwide footprint, and they're beholden to many countries and many places around the world to supply vaccine. So we really need help to help these manufacturers speed production. And also, as we look towards newer vaccines, we have to think about the very same thing, because what we should be doing is making sure that we are producing somewhere between 10 to 15 million doses of vaccine every week so we can distribute it.
Wow, that seems like a tall order. So short supply is one issue. Another issue that we've reported about is disparity in terms of who is getting the vaccine. Is the vaccine reaching enough people of color? And if it isn't, why not? Renee or
Well, I mean, well, first of all, 1A was our healthcare professionals. And I think, in those percentages we've seen in the first 16 states, I mean, I guess we could make some assumptions that the workforce is not made up of a large percentage of African Americans, and that may impact that number. So I will assume that maybe that's why our rates are different. I also say that those rates are probably different because of transportation. As I looked at pictures across the country with lines, if you don't have a car, then you can't very well drive to a location to get a vaccine. If you are a senior or have any limitations, you are have barriers then to getting to the vaccine. I know in my mind, as we look to strategies locally, I was like, well, we can use mapping to tell us where people live. And can't we bring the vaccine to where people are? Because we have the data to tell us that. And so, I'm not planning at the federal level, but I think at the local level, we know that we can identify where we need to be. We can identify what locations we can convert into quick sites for vaccine dissemination. And so I think that's the only way to ensure equity. Because I think, when we do it ways that we just think it's simple, it usually involves transportation. So
Larry, go ahead, Larry. I was going to say you've done a lot of reporting on this. What have you learned about that?
Well, I think it's interesting what Renee just brought up about sort of collaborating and getting transportation. I know the city of Cincinnati partnering with Hamilton County and others, working on ways to sort of make sure people have that access. I don't know how many times I've gone to do a story where you have someone that says, hey, I'm in a group of people where we have a higher death rate than others, right? We have more severe illness from COVID-19 than others. Why were we not priority 1B at least? And that's something that didn't happen. Those questions were asked. But of course, the answers that we heard from the state were sort of almost like a filter down effect. Well, we'll start with the healthcare workers, the nursing homes, et cetera, and you will see some of the minority populations get vaccine, and that can affect some of these rates here. But you still have the disparity. And off the top, we mentioned the supply, and it just keeps coming back to that. I hate to keep mentioning it, but there's just not enough places to turn.
Not enough places to turn. And when you see certain things, it makes you wonder, okay, why did they get some and why didn't? To your point, for instance, I spoke with Governor Beshear a little earlier today, and he talked about the 5,000 extra doses that they were getting or it was a percentage more that they were getting. And so if you're in Ohio, you're automatically wondering, well, what about Ohio? And what's the, how does that happen? I guess that's my next question for Dr. Fichtenbaum. How are these supply allotments allocated? What's the rhyme or reason behind that?
Yeah, well, the supply allocation came originally from Operation Warp Speed. And there were a number of different metrics that they first started to look at. One of the early things they were looking at was, where is the infection the greatest? Where are the hot spots, right? Well, as it turned out, when it was time to roll out vaccine, you didn't have to have a special map. All you had to do was open your eyes up and see the United States of America was a hot spot. Granted, some places more than others. But then it came down to, they were starting to think, well, where are the places where the hospitals are taxed the most? There was a lot of machination trying to think through, we only have a limited supply. We had less than we thought we were going to get from Pfizer. And we know we have some of these cold storage chain issues. So how do we get this vaccine out to places? And, they went through the process of talking to the states and saying, can you identify places where you can get the vaccine? Doctors across the state of Ohio got a message saying, do you want to be a vaccine provider? Do you have a really cold freezer? Can you get this stuff? Right. And so, starting to think about this. And of course, many of the hospital systems were the places where they really could get this, and be able to give vaccine. And so that's where it sort of started going. But what you see from all of this is the tremendous imprint of systemic racism. And what that means is that when people start to think about planning and groups and things like that, there are all sorts of stipulations and rules about, well, we're going to give it to first line providers, but now we want to make sure that, do you actually have contact with COVID? Well, so if you have somebody who's running around the hospital who may be cleaning the floors or something like that, they have a lot of contact, but not every hospital like ours prioritize those people. It was very different in different places. We recognized, and in part because there are loud voices like mine that sit there and say, these are people who have contact with patients and they're very much at risk and we absolutely need them. They're essential. And there were many other people in our leadership who absolutely agreed, but that's not true at every hospital. You saw some places across the country where their board members got vaccine and things like that. And where lower wage workers work are more people of color. So you see individuals, again, where we don't get the access to it because, well, we're going to give it to the nurses and the doctors. And where's the predominance of who's who in all of the communities? So I think it illustrates many different problems on many different levels. And we sure made this really complicated. And we did it because, as Larry says, we don't have enough vaccines. So we have to make choices.
And a thing that I've heard from people that I've interviewed that have run into, I can't get the vaccine, there's that disappointment of, is it really for me then, right? They wonder if this is something they should continue to pursue. If I put all this effort and all this energy and I'm continuing to be told no, should I keep going after this? And of course, the doctors and scientists say, absolutely, we need to reach herd immunity. I interviewed a gentleman just last week who is in an eligible category in Kentucky. And he tried and he could not find vaccine, primarily because he couldn't get an appointment online, and he struggled with that. And as you mentioned, I think we mentioned that hospital systems and phones, that they want to reserve that for the people that have no choice. We actually helped him get a human on the phone and got vaccine, and he wound up getting a vaccine for himself as well as for his wife, but it took a lot of effort. And he told us, I want to share my story so that people do not give up, because I know some of my peers have just said, oh, well,
Yeah.
I guess I'm not really the priority.
But here's the question, should it take that much effort to get a vaccine that is supposed to save your life, perhaps?
I don't think that it should, and I'll have to use my father as an example. He's 77 years old, and he said, well, I'm just going to go through the process that they told me. And so every day I'll check with him. I was like, okay, Dad, you need to go check this site at this time of the morning. And he's like, I did it, and he did it, and I did it, and there were no appointments available. Now, he is going to be persistent, and he's going to keep trying, but again, not everyone, as Larry said, has, at some point you kind of say, well, wait a minute, like, okay, well, I think I'm just gonna take my chances. Um, and that's not what we want, right? And unfortunately that word of mouth spreads. So, someone can tell someone else and say, hey, you know what, I couldn't get the vaccine. I don't, they said it was here, but I don't think we're going to get it. So that's very frightening.
Yeah, so Renee is one of the smartest women I know. And she and I were having a conversation just the other day, and we were talking about how do we make this better. And she's absolutely right. It's like anticipating that best date you ever had. And you're sitting there looking at the clock, and they're never showing, they're never showing, they're never showing. And finally, you just give up and say, this date ain't never going to happen. And I'm going back home. I'm going to go watch a movie on Netflix. So we're trying to say to ourselves, we have to be very careful about how we organize this, because we have to be ready with vaccine. When we're ready with vaccine, that's when we can get people excited. Because here's the thing about that great date. If they call you 2.5 weeks later, I bet you still go on that date. And so if we can come back and get that vaccine, then I know that people will come back. But we have to make it available. We got to go to the people.
Okay.
And that's really important.
Okay, so this is our finishing thought. We have about 2.5 minutes. I'd like each of you to take about 30, 45 seconds. What's your fix? If you were in charge, what would you do differently in terms of being able to get vaccine out to the public?
Well, I'll start out.
Okay.
I think we got to make it much more simple. I think it's too complicated. And what we have to do is we have to figure out, we have to get some people together in a room, do some really good planning, and say, where do we need to get this vaccine and how are we going to get it to the people? Come up with a really good plan, and then wait for the vaccine, and then begin to just say, we're going to be here at this location, and you can come get your vaccine. And have people come, and make sure we call people and tell them. And then we have to say on a really consistent basis, we're going to do this again and again each week, different place.
Okay, Renee, do you think it should be centralized like that?
I do think it should be centralized. I think we learned a lot from COVID testing. When COVID testing wasn't reaching the populations disproportionately impacted, all of a sudden we said, let's flip it. Let's look at where people are, and let's stand up those sites there. And once we did that, then we were able to reach more people. So I'm scratching my head in this whole process, because we have all kinds of geo mapping and data capabilities. We know where people live. We know what facilities are near them that can be converted to vaccine sites. So if I had my wand and I could wave it, I would say, pull out that map. Let's look at where people live. Let's look at where the disproportionate number of people are disadvantaged by transportation. And let's make sure that we put sites that are easily accessible, and that we coordinate that with other agencies that can transport people in the event that they have to go a mile. And so that's what I think we should do. I think all hands should be on deck. I think we should use all our public entities to help identify the quickest ways to get people to the vaccination point.
All right, Larry Seward, you have the final word, about 30 seconds. Go ahead.
That's dangerous. I'm not as smart as Dr. Fichtenbaum or Renee, but here's what I'll say is that the setup in Ohio, where you can get it through universities, through federally qualified health centers, pharmacies, there are 4 places. Indiana, it's one, the state, at the hospitals. I would look at something where it is simpler, where you're not having a bunch of phone numbers, a bunch of different places to try to track down and call and search for appointments to get the vaccine. I think that is crucial, because I see a lot of people frustrated with running into dead ends, and then they see someone else find a workaround, and then they wonder why.